Welcome to my podcast. My name is Dr. Brendan McCarthy, and I am the Chief Medical Officer of Protea Medical Center in Tempe, Arizona. And today we are coming from our new studio that we've been working on. It's still a work in progress. Evelyn, the producer of the podcast, has been working very hard at getting the space set up for us. We're trying to find the right colors, lighting, and everything, and the right decorations to do. We've been migrating this from my house for a while now. Once we have the room set, as I mentioned last episode, we will have both the dogs here for my filming, because I love having them around anyway, but they seem to be a part of the show. It is. So as it stands. So today we're going to delve a little bit more into migraines and the treatment of migraines and what causes migraines in women. And I want to remind you, this is a part of a series that we're doing, and I want to remind you very important thing that I brought up in the beginning, and I think it's important to keep hammering back to. This is why this is important, is that this show, my podcast, is not meant to take the place of you having a physician. It's not. I want you to have good care. That's all I want. That's it. That's why this is here. My goal is to give you as much information so that you feel educated, so that when you go into that space with your physician, you're able to advocate for yourself using clear terms that physician will understand. When you go to the doctors for migraines, often you're not well treated. And I know this because I've listened for years. Sometimes you are heard. And those times often tend to be when you have a neurological condition triggering your migraines. Sometimes there is a tumor. Sometimes there is pathology that needs to be ruled out and cared for. With that said, the vast majority of you are not. And I want to point something out here. When someone just prescribes you a medication to stop your migraines without telling you why you're having migraines, that's not good care. That's not complete care. That's symptom management. I'm not telling you to stop taking that medication. That's not my answer. That's not what I'm saying. What I am saying is you deserve your physician to do a deep dive. This is what we're here for. This is what a doctor is supposed to do. Our goal is to do a deep dive to understand exactly why you're having that migraine, and then figure out how we can stop it from occurring in the future. Can we find a balance in your body? Can we come to a solution? Is this due to an estrogen fluctuation? Is this due to a progesterone deficiency? Is this due to a neurotransmitter deficit due to an inborn error of metabolism? Say you have MTHFR. There's all these things that we want to understand, because if we fix the original cause, you wouldn't need the medication. Now, sometimes we'll find what the cause is, but you still need that medication. In that case, we still did a good job, because we went down the road to understand why you are where you are, and we did our best to understand every aspect of it. And then we do our best to restore you to the best sense of balance you can have. And these episodes are about discussing that with you. Why I'm saying this is that I don't want you to watch this or listen to this and think that your migraines are only going to be the things that I'm talking about on this podcast. This is not meant to be completely exhaustive, and it's not. I went to med school, I had to take neurology, I had to take all these classes. I had to learn all the different things, so many things. So when I treat a migraine, I'm thinking about everything. I screen for everything. I'm running it all back here. When I do these episodes, it's me calling out the areas that I think are being missed and where I think you may be falling through the cracks, and me trying to be helpful for you. So please just take that when you watch these episodes, take that to heart and watch these episodes through that lens, knowing that while this might be it, you want to do a full workup, the best that you can get. You deserve that. So, with that said, let's get into the episode. But before I do, as I always say, if you like what I'm doing here, if you like the material, press like. If you find this is something that benefits you throughout your life, subscribe. Sure there's a tab somewhere. If you're watching this video like YouTube, how we're doing this right now, you can just scroll down there. There's a little thing, right? And then I don't know if you're on Spotify or you're on Apple Podcasts or whatever platform you're on, subscribe. And then if you have a comment, something you think that I could do better with, send it to me. I read them. I really do read them a lot. And there's one that I got like a year and a half ago that I've been still thinking about. This is how my brain works. I sit back and I get that feedback. It helps me become a better doctor, but also helps me become a better service to you in these moments. Your comments do help. And then finally, if you know someone that would benefit from this, you never know by giving them this video, by sharing it, what it would do. There are people that once they just needed to know, they needed to take this, say last episode, we were talking about magnesium. What if they just take magnesium at that dose? All of a sudden the migraine went away, and that's what it was. Estrogen fluctuations, that's what it was. And they never knew. They never knew to ask their doctor, and they just needed to see that one snippet. So never underestimate the value of sharing information with someone that you think it would benefit them. Worst thing that'll happen is they'll watch and it really didn't help them, but at least there was effort. So, all right, let's get into that material. Last time I was talking about, estrogen and how estrogen leads to migraines and the role of estrogen. And I talked about lab work and how to process it. I talked about different supplements. I talked about how to process estrogen through the body a little bit better. Now I want to go over the other half of the equation. I want to talk about progesterone. Now the estrogen one, if you will remember, I talked about it in terms of your ability to produce monoamines. That's going to be serotonin and of course melatonin. I talked about how serotonin deficits are associated with migraines. That is one component of this that's really important. The other one, now with progesterone, I'm going to talk about the GABA pathways, gamma aminobutyric acid, GABA. That's the anti-anxiety part of the brain. That's where progesterone shines. I'm also going to talk about the neuroprotective component of progesterone, how the role it plays in reducing neural inflammation, the role it plays in modulating nociceptive receptors or pain receptors in the brain. So progesterone is very important. And actually, that's one of the most important ones. But I didn't want to forget estrogen. So we're talking about progesterone today, my second part of that. And it's my first favorite, though. So progesterone. During a cycle, just to remind you how this works, your first 2 weeks of your cycle, you're going to be increasing your levels of estrogen. That's normal. And your estrogen should be moving upwards wherever you are in your age and your fertility, your estrogen is going to be at that level. And then around day 12 of your cycle, you should ovulate. Some women will be a little bit before, someone will be a little bit later. But when you ovulate, estrogen levels should go down, and then progesterone levels should come up, and progesterone should become dominant. Now, estrogen caused all that tissue that's associated with fertility to be stimulated, like breast tissue stimulated, lining the uterus, bones, all these things are being, and that's good that it does that for those first 2 weeks. And then when progesterone comes up, progesterone goes to that same tissue, calms it down, and it organizes the lining of the uterus. It gets better blood flow to it. It lobulizes the breast tissue. It's important, the role that it plays in modulating the pro-growth component of estrogen. So you need progesterone physically in that sense. The other part of progesterone, where it's so important, it gets forgotten about a lot in medicine, is that progesterone also crosses the blood-brain barrier, and it gets converted to something called allopregnanolone. Allopregnanolone is beautiful in the sense that it binds to that GABA receptor, and it modulates anxiety, and it reduces anxiety in women. We know that women who don't ovulate very well with low levels of progesterone, they tend to their brains move towards anxiety. And this is due to that allopregnanolone pathway being deficit. There are so many studies that have been published that show how GABA is associated with migraines. So GABA is that anxiety part of the brain, as I mentioned, absolutely. But GABA is also, it modulates your neural tissue. You'll have stimulatory pathways and you'll have inhibitory pathways. GABA is more the inhibitory. And too much GABA is not good. Like if you took a lot of like a benzo like Valium at really high dose, you just out, right? Because you're basically taking the brain waves. So think of like a brain waves like going like this, What the GABA pathway does, what progesterone through the GABA pathway, it brings it in. It doesn't let it keep going really wide. So it kind of is like a shock absorber. It doesn't let that frequency go wide. When you have too much, it shuts it down too much. We have none, it goes really wide. So that's the excitatory, and then you have the inhibition. You want a little inhibition just to bring it back in. The research is really clear with the role that GABA plays in migraines in women. So when you don't have any of that GABA action from allopregnanolone, there's no buffer, things go whipsaw. You do like a scan of the brain, and the brain has these, you can read the brain waves. And what that whipsaw is like in the brain, it's just, you're just firing neuron after neuron after neuron, and it's too excitatory. And this is associated with migraines. Further, if you fire these neurotransmitters over and over and over again without GABA calming things down a little bit, it becomes more pro-inflammatory at the neural tissue, because the neurons releasing all these neurotransmitter packets across that membrane, and that becomes more pro-inflammatory. So when a woman doesn't ovulate and has low progesterone, we open this window, not just to anxiety, but also to migraine. It is part of our job as a physician to run the lab work to see the deficit in the progesterone in their labs and try and treat from there to restore that balance and to see if that eliminates the migraine. But that's not all. It's important to understand what other things could be at play here. What could be causing it? Because just giving you just progesterone, it's better. We're helping. We're solving one of the big parts of the problem. But the other part of the problem is, why aren't you ovulating? What's happening here? Why do you have that? Stress is an awful thing. Stress out of control is an awful thing. We need some stress. Exercising at the gym is stress, but it's positive stress. It's controlled stress. But uncontrolled stress, excessive stress, when you're not sleeping well, when you have all these responsibilities stacked onto you, when you're running the house, managing the kids, putting food on the table, working at a job, cleaning up, when you have a work relationship that's not good, a home relationship, a marriage that's not good. These things all contribute to stress. When your body is under stress, your body wants to preferentially make cortisol. So it's going to push the metabolic pathway to generate cortisol. On that metabolic pathway lies pregnenolone and progesterone. So what your body does is it preferentially pushes the pathway, and it takes pregnenolone and progesterone and it drives it towards the production of cortisol. So it reduces your natural production of progesterone and pregnenolone. Stress is has a huge association with migraines. One, because when you have a migraine, that's a stressor. Pain like that, there's nothing like it. It's a unique pain in and of itself. But also, having stress in your life will contribute to this. So it's like a chicken and egg thing. It just kind of feeds forward. It creates itself. It builds upon itself. When a woman presents to clinic, it's important that I assess why they're low in progesterone. Is it because they're not ovulating? Why aren't they ovulating? Sometimes ovulating is due to diet. Sometimes it's due to lifestyle. Fine, I'll get that. But is it due to stress? I need to run a panel where I'm going to watch and see what their cortisol is doing, what their pregnenolone is doing, what their progesterone is doing, and I do that whole pathway to understand them. So in the treatment of these women, in the treatment of them, while I'm understanding what's causing it, and I'm going to do my best as a physician to give them advice and how to manage this source of stress, sometimes these women, this is the only person they need to speak to. I'm the only person they'll talk to about this. I'm the first person in a lot of ways. I'm that person screening it. And my goal is like, okay, if this is the kind of stress, do I need to refer to therapy? Do I need to share with them that this is unreasonable to expect themselves to be working, 14 hours a day without any downtime? What is my role to help them in managing their stress? I will figure that out with the individual woman per case. But how do I manage them? How do I manage this biological irregularity while I'm trying to go after the source of the problem? I run their labs, as I mentioned, day 21 of their cycle. That should be the luteal phase where their progesterone should be at its highest. I want the progesterone above 10. So if the progesterone is not above 10, I'm going to prescribe progesterone. I'll do 200 to 400 milligrams at night before bed. Now, the version I use the most is the one that dissolves under the tongue. I have that compounded. That has the best absorption. When you swallow progesterone as a pill, your absorption rate starts to drop. Now, some women will do a topical progesterone. I don't have the greatest success with topical progesterone. They'll do transvaginal progesterone. I'm kind of iffy on that because if you do transvaginal progesterone and you have intercourse with your partner, that's going to be on them. They're going to be exposed to that. So I'm always cautious with these transvaginal routes. Some will do a suppository, which is a transrectal route. That has benefit, but make sure that what you're using is a suppository. Someone will actually take a capsule and insert that transrectal as a suppository, but a capsule is not made to break down that way. An oral coated capsule won't break down in the rectum. It needs to be one that's specifically made to be a suppository. So how you get it in your body matters. And I've done many episodes on that. You're more than welcome to look back over those older ones. You'll see it in the archive of our page. But I want to make sure I get enough into them, again, between 200 and 400. Sometimes it goes as high as 600, so long as I see that lab value move in the right direction. What else do I do? Pregnenolone is a supplement. So in America, in the United States, pregnenolone is available over the counter as a supplement. Pregnenolone is a precursor to that neural steroid. It's something that's made in your adrenal gland. It's a precursor. And you can buy that, in 30 milligram increments. We usually use 30 milligram capsules and go up the dose from there. When you run the labs for pregnenolone should be in the neighborhood of about 80 to 120. That's been my experience. It's been my benefits. You can go as high as 150 on the labs, but the 80, 110, 120 maybe. That's where it should be. Women below that, you tend to see that's where they're having issues. Now, pregnenolone is not just migraines. Pregnenolone also plays a role with, PMS and PMDD. Plays a role with insomnia with women. It's that whole pathway, that GABA pathway has a lot of different things it leads to with people symptom-wise. So pregnenolone is one of my favorite tools to use in this sense because it's very helpful. I know out there's going to be other doctors who are going to watch this video who are going to give me a hard time right now. They're going to say, you're testing pregnenolone in the blood, and that doesn't mean that's how much allopregnenolone is inside the brain. And that's not accurate. The research is very clear that when you test serum pregnenolone, that is a good indicator of how much allopregnenolone is in the brain. The research is very clear that when you give a woman oral pregnenolone, you will increase her allopregnenolone. And I'll put those two citations in the notes at the bottom of this video because this is an important thing because I'm asking for your trust with this. And I want you to know this, even with an over-the-counter supplement that's as benign as pregnenolone is, I'm still working hard to make sure I earn your trust, that I'm not just making this up. I'm not just throwing something at you saying, that sounds like a good idea. Nope, I'm doing the hard work, and I believe every doctor needs to do that with you. So when you take pregnenolone in my office, when I prescribe that for you for your migraine, along with progesterone, in the hopes that I'm going to get benefit with you, I'm running the lab work to make sure it's doing something. I'm sitting down with you to make sure that you're coming back with better results. So we do pregnenolone over the counter, as I mentioned, 30 milligrams at night before bed to start. I go as high as 90 milligrams. That's about as far as I need to go. And I run that lab about a month later to verify. I didn't mention this a minute ago. Let me back up a second. With the progesterone, you only take that the last 10 days of your cycle during the luteal phase. That's when you take your progesterone. That's the approach that I take with migraines that are associated with a progesterone deficit. And it's associated more with PMS and during that time of the month, whether PMS and PMDD, they tend to have migraines in that timeline as well. And sometimes they don't have PMS or PMDD, they just have that migraine due to low progesterone. You don't always have to have classic symptoms for you to be valid with this diagnosis. You notice I didn't bring up birth control. I'm not going to. I am, but I'm not going to say it's a therapy. It's not a therapy for this. It's not a therapy for this. I should have brought this up in the estrogen one, so I'm going to bring it up now. Why we don't use oral contraceptives for migraines. Why I'm going to tell you that's not the best idea. Well, if you have migraine with aura and you're taking oral contraceptives, your risks for a stroke go up. Why is that? We know that there's a constriction that happens in the brain during a migraine. We know that there's inflammatory things going on in the brain during that time that could be stimulating your body to want to coagulate, making more coagulant state where your body's going to throw a clot. When you take oral contraceptives, the estrogen that's in there first passes through the liver, gets converted to something called estrone at a very high rate. Estrone is one of your estrogens. You're supposed to have it, but it needs to be in a ratio with your estradiol. If your estrone is elevated, it's going to stimulate something called thrombin. It's basically stimulates your body to want to make more clots. Your body's want to coagulate a little bit more. So if you have the migraine with the contraction occurring with the inflammation, pro-inflammatory cytokines and prostaglandins going on, and then I throw estrone and more thrombin in there, what am I doing? That's a recipe for a bad thing. So just know that I will not prescribe that in the face of migraines. What if it's a progesterone-induced migraine, Brendan, and not estrogen? What if it's that? What's going on with that one? Why not just progesterone, a progesterone-only pill, Brendan? Why not that? Because you're getting the progesterone from the pill, from the progesterone-only pill, that'll help their brain, right? No. The progesterone that's in oral contraceptives is not natural, meaning it is not progesterone. It's a synthetic compound that has molecular mimicry. It acts like progesterone somewhat. It has a similar effect to progesterone, but it does not cross the blood-brain barrier and make allopregnanolone. It does not have any benefit down that pathway. It does not impact the brain in a positive way whatsoever. So that's why we don't recommend oral contraceptives for migraines. Now, some women who take contraceptives will notice their migraines are less. Why is that? You're suppressing all of your estrogen at that point. No estrogen's on board. Your natural biological estrogen, your ovaries are not making anymore. So what you've done is you've managed those spikes and drops of your estrogen that were happening previously. So women who have migraines associated with those wild fluctuations in estrogen, that will help them, but at the cost of a higher risk for clots. If your migraines are more associated with that GABA pathway, the anxiety part of the brain, the gamma aminobutyric acid pathway, birth control is not going to help at all because it's not having the positive neurosteroid pathway being turned on. Okay, that was a lot. It was a lot. I really wanted in this moment to reach out to that one woman out there. You're out there somewhere who has these migraines, and this is yours. And I'm hoping you hear this. I'm hoping this helps you. I'm hoping this gives you tools that you can use when you're sitting with your doctor's office, and these are things that'll help you long term. Next episode, we're going to come into this and we're going to talk about other pathways. We're going to close up with it. I'm going to talk a little bit more of neurotransmitter deficits associated with inborn errors of metabolism, or things you're born with genetic deficits where you can't make certain neurotransmitters. We'll go down that pathway together. That's our next episode. So until then, thank you so much for tuning in, and I will see you in the next episode.